Okay, I just wait for maybe 2 minutes or 3 minutes. Okay. Can everyone see my screen?
Yes.
Okay.
Yeah.
Okay. Can we wait for a while? And Dr. Kaushik, when you feel like I can start, you just let me know.
Yes, we'll wait till around 20 people join, then we can
Okay.
start.
Okay.
If you want, I think you can take start because we have we'll find some candidates for the first question also. I think we can start.
Okay. Hi. I will start now. Okay. Good evening. My name is Dr. Logan. I'm from Malaysia. Sorry, I start a bit earlier for you all. Okay. Can anyone unmute? Okay. Yeah, it's
Yes,
just that it's now
I
8
have
o'clock here. Yeah.
Dr. Logan.
So,
I
yeah.
have given permission to around 4 people who can mute other people's. So
Okay.
if anybody is not speaking and their mic is on, please
Yeah.
mute that. All other
Okay.
co-hosts.
Okay.
I think please, Dr. Logan, you can
Okay.
start.
Yeah. Okay. Yeah. Sorry, I will start now because it's 8 o'clock here. Okay. Anyway, I only got 5 cases and I would like to have 5 candidates that would appear in the exam to try this. Okay. Who's going to try the first case? I prefer the candidate who's going for the nearest exam to
I
participate.
will volunteer, Dr. Logan. I am Anirban.
Okay, okay, Dr. Anil. Okay, we are going to start now. This is case 1. Okay, please describe this picture.
Okay. This is a fundus photograph of both the eyes, collage, showing that showing clear media in both eyes. The optic disc appears to be pale. There appears to be optic disc pallor in both the eyes. The margins
Okay.
are clear. The blood vessels are reduced, and there doesn't seem to be any surrounding disc
Okay, so
edema.
what was your impression based on this picture?
This looks like optic atrophy, both
No, no,
eyes.
no, 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 not any diagnosis. What is your findings of this picture? Conclusion of your findings?
Uh, okay, my finding is this is optic. There is pallor of the optic disc in both the eyes.
Okay, so it's a both eye dispeller. Okay, and
Yes,
then
yes.
what is this? Can you please describe this?
Okay, these are printouts of the visual field, of the right as well as the left eye. So I am not able to read the reliability criteria. The font is
Can
too
you see my
small right now.
pointer, my mouse
Yeah,
here? Okay,
yes,
you
I can
just
see.
describe this, you look at this, and you look at this. What you see here?
Okay, so I am seeing area of of scotoma paracentral to the fixation. There is some paracentral scotoma, and it is also
Oh,
involving the blind spot,
okay, so
suggesting a
what is your
centrocecal scotoma.
conclusion of your finding?
This is a bilateral centrocecal scotoma, sir.
Okay, or secocitral, okay, I accept that. Okay, so based on the fundus photo and the visual field, can you give some differential diagnosis?
Okay, my differentials would be for a bilateral centrocecal scotoma with bilateral optic disc pallor. I would think of toxic optic neuropathy. That would be one. Second would be other than this, hey, mm, other than toxic optic neuropathy, optic healed or resolved optic neuritis. old optic neuritis in both the eyes.
Other
And
than that, can you give 2 or 3 more?
yes, hello.
Can you give 2 or 3 more example? More differential diagnosis.
Two what example, sir? Sorry.
No, can you give more differential diagnosis?
Yes, for centrocecal scotoma, other than these two,
Light and current.
What is the most important that you need to tell? Okay, it's okay. Can anyone please mute the? I don't want, please, other candidate don't answer and don't answer anything in the chat. Okay. So you don't have any other differential diagnosis at this point.
no, I'm thinking of
It's okay. Okay,
awesome.
let's say that this is a 33-year-old man, noted that his vision slowly deteriorate over many years. So what you will do?
Over several years.
Yes, several years. 33-year-old man noted that his vision slowly deteriorate over many years.
I would like to take a history of uh, whether there is any malnutrition or alcohol abuse or excessive smoking. That would be one. When did he notice the onset of the reduction in vision? I would also think about if it's a 33-year-old man, quite young, so and it's a bilateral etiology, so hereditary optic neuropathy could also be a possibility.
Okay, so that's your history. So how you examine this patient?
Okay, so I will start by documenting the visual acuity.
Okay, visual
And I
acuity
will
is
check
6/24 over both eyes.
both eyes. Okay, and then I will document the intraocular pressure.
Intraocular
And
pressure is normal.
okay, and then I will check the pupillary reflexes, direct and consensual for both the eyes, as well as
Okay, it's
RAPD
normal.
using swinging flashlight. Normal.
Why
Okay.
you want to check RAPD?
Yeah, it will not be
Okay,
there.
let's say that what you expect to find RAPD for this patient.
There shouldn't be RAPD because the optic disc pathology is symmetrical.
Okay. Other than that, what other examination you want, or how you want to examine?
I will check the visual fields
Okay.
by
We
confrontation.
already give the visual field here, so it's a
Yes,
center.
and
So other than that,
yes, then I will go for a detailed slit lamp examination.
no.
And
Before that, what else?
before that, I will check the extraocular movements and do a cranial nerve examination for the
Okay,
third,
extraocular
fourth, and
movement is
sixth.
normal, cranial nerve normal. What else?
Other than I would
Come on, what else? Important. What is optic nerve function test? What else?
I will check for the color vision. I
Okay,
will check
the
for color
patient got
desaturation.
red-green color blindness. Okay.
Okay.
Okay, so now slit lamp, what you want to look for?
Red. If patient is having red-green color blindness.
No, in the
On the
slit lamp,
slit
what
lamp.
you want to look for? How you examine patient in the slit lamp?
Oh, I will examine the patient. I will first
No,
use
what you want
diffuse
to tell the
illumination.
findings in the findings of your examination of this patient in the slit lamp?
Okay. When I start examining the patient, I will first use diffuse illumination and examine the ocular
Okay. So
adnexia.
anterior segment is normal, and posterior segment you already find in the picture. So what you want to do next?
Other than this,
what investigation that available in your clinic that you want to do?
other than this,
what investigation that available in your clinic to look for posterior segment pathology? Non-invasive.
Non-invasively, which okay. So I would like to go for an OCT and a fundus.
Okay.
Yeah.
Okay, what is the OCT here finding?
Okay.
Now look at this section. What is this? Look at this section. only here.
Yes. So this section is showing thinning of the retinal nerve fiber
Okay,
layers.
okay. So
Mm.
what other investigation you want to do for this patient, step by step? Other systemic investigation that you would like to do based on your differential diagnosis.
I would like to, yes, sir. Uh, in this case, I would like to take blood samples
Okay,
for
what blood sample you
vitamin.
want to take?
I would like to check the blood levels for vitamin B1 and B12.
No. Basic, step by step. I tell you, step by
Uh,
step, what you want to take.
okay, okay. I will check the complete blood count and the total and TLC
Okay,
and
what you want to, why you
DLC as
want to take complete blood count?
well. To check whether there is any uh, to check whether there is any
Come on, what's that? What you want to check for full blood count?
in the full blood count, I will be checking for whether there is any infection or
Yeah, so differential diagnosis, in fact, if you missed just now. Okay, others, what investigation?
okay. Other than this, I would go for
Okay, quickly, what is serological investigation you want to take?
okay. Bilateral optic disc pallor in a young male. Serologically, I would check for syphilis,
Okay,
VDRL,
okay, other than that?
VDRL and TPHA, and mm,
I mean, routinely, how you check for any patients, for any serology?
okay,
Basic. What
okay.
serology?
Then I will be doing the I will check the for serology I will check the VDRL, the TPHA. I will get an HIV test done.
No. Come on, autoimmune. You one of the differential autoimmune. So what basic you want to take?
Okay, if it is autoimmune, then I will think of if it's a young male, I would like to check for C ANCA, P ANCA if he has a
Okay.
systemic history of that.
Basic. Other than that, very basic, simple.
Okay.
Okay, it's okay. Let's move on. Okay, after laboratory investigation, what else you want to do?
After necessary investigations, I would like to uh, I would like to get the I would be suspecting a nutritional optic neuropathy here initially.
No. We forget about
Yeah.
nutrition. Okay, you just
Yes.
move on.
Okay.
After laboratory, what else you want to do?
Okay. Other than this, mm,
Other investigation. Come on, other investigation.
once the OCT is done,
Yeah.
okay.
Other investigation. You are saying optic disc failure. What important investigation you want to do?
Mm, okay. Optic disc pallor. Other investigations will be
What is the most important investigation? Life-threatening condition you want to rule out? What investigation you want to do?
okay. Life-threatening. If he's a young male,
No.
so
Tell me what investigation you must do.
I have to check for the ESRs.
No. Forget about lab.
Uh,
What important investigation you must do? It's an optic disc fail.
hmm. Hmm.
What is the
Bilateral
yes? What is the cause? What is the important investigation?
compressive lesion has to be there, so
So
we
what
have
you
to
want to
go
do?
for a neuroimage. I will do
Okay.
a neuroimaging, an
Okay.
MRI
Tell
with
me what
contrast.
you find here.
Okay, so here is this is a coronal section of an MRI scan showing
What MRI? What type of MRI is this?
this will be a T1 MRI with contrast.
Are you sure?
I am not sure.
Okay, it's okay. Let me say that this is the T2 MRI. Okay, what you find here?
There seems to be uh, a hyper intense mass inferiorly.
Okay, so you are not that sure. Okay.
Hmm.
Okay, fine. I tell that MRI is normal. There's no any compressive lesion and everything. Okay, so what else you want to do?
I would also ask for a venogram to be done as well?
No. Forget about imaging now. What else you want to do? You do all the
Okay.
blood investigation, everything, and you do the MRI and everything normal. So what you must do? Patient having both eyes failure. What you must do?
Hmm. Okay, so if MRI is also normal, then
Come quickly. What you want to do?
hmm, I
Okay.
would
What you want to
like
do?
in this. Yes, I'm not sure, sir. After
Okay,
this,
okay. We stop here. Okay, okay. We stop this first. Okay. So the candidate, I find that yeah, you have something, but just what I expect you to answer, you didn't answer. You need to refer this
hmm,
patient for any neurologist, anything to do more some CSF analysis or anything. Okay.
okay.
Okay, and then other than that, you need to know your differential diagnosis. Okay, it's very important.
Hmm,
Okay.
hmm.
Okay, let's we move on for the second case. Okay. Okay, who's going to try this case?
Hello, I can try this.
And you
My
are?
name is Dr. Prabhat.
Okay, Dr. Prabhaj. Okay. You are ready?
Yes.
Okay. This is 25-year-old lady developed a subacute blurring of vision in the right eye at 35 weeks into her first pregnancy. This gradually worsened. There was no pain and no other symptom. There had been no prior neurological symptoms. There had been no complication of pregnancy and her blood pressure was normal. There was no proteinuria. Okay. How do you examine this patient?
She is complaining of blurring of vision. So I would like to take history of the blurring of
No,
vision.
forget about history. I asked specifically how you examine her.
Okay. Visual acuity.
Okay, visual
distance
acuity for the
near.
right eye is 6.9 and left eye is 6.6.
Okay. Color vision.
Color vision is reduced in the right eye.
Okay. Pupillary evaluation.
There is what type of pupillary evaluation?
Light. Light reflects direct and consensual and check for relative apparent pupillary
There's
defect.
a right eye RAPD.
Okay. Slit lamp evaluation.
No, before slit lamp.
Ocular motility.
Full.
Okay. Slit lamp evaluation.
No, before that. Come on. What else? At least one more. What else? What else you must know? What else you must check for optic nerve? Hello?
Yes,
Are you there? Yeah.
confrontational fields.
Yes, okay. Central visual field defect. Okay. Now you proceed with slit lamp. Okay.
Yes.
Okay. Anterior segment is normal.
Okay.
Okay.
Intraocular pressure.
Okay. This is posterior segment. Intraocular pressure is normal. This is posterior
Okay.
segment. Can you comment on this?
Yes. This is fundus photograph of both eyes. On the left side is the left eye photograph, and on the right side is the right eye photograph. The left eye photograph shows a clear media with a apparently healthy optic disc and
Which
normal
eye?
left eye.
Okay.
Left eye is on the left side and right eye is on the right side.
Okay.
So left eye fundus appears normal with a healthy
Okay.
optic disc.
Okay.
Right eye fundus shows clear media with blurred margins of the disc, with vessels arising from the center of the disc and normal foveal reflex.
So what is the optic disc of the right eye?
Edematous. It's a disc
Okay.
edema.
Or swelling. Okay. So based on all these things, what is your impression? All the history, examination, and all this finding. What is your, give me now your impression? Hello?
Possibility of raised intracranial pressure.
No, I don't want anything. I just want what is your impression, means early diagnosis. What is your diagnosis here for this patient? Okay, what's the patient having right eye teeth swelling? Okay. Okay, based on all the RAPT positive everything, what is the diagnosis for this patient?
Optic neuritis?
No, not what is the diagnosis for this patient?
I don't know.
Okay, this patient having right eye optic neuropathy. Okay.
Okay.
Okay, can you give differential diagnosis for optic neuropathy?
Optic neuritis, papilledema.
Hey, why papilloedema?
No, in this case, it will not be a differential.
No,
but,
then don't mention all these things. You just give me differential diagnosis for optic neuropathy.
Okay, disc edema due to any compressive optic neuropathy of some orbital cause that will only cause unilateral disc edema. And
What else?
pseudo disc edema could also occur.
What else?
Any possibility of malignant hypertension, pregnancy-induced hypertension?
No, we are now clear. You are going, I already give, you must think your mind. You already fixed that this is optic neuropathy. Okay, so there's no any role for any pseudotis or any malignant hypertension, everything. So you give me differential diagnosis for optic neuropathy. This is unilateral, correct, right? So what's the differential diagnosis you want to give? You told me optic neuritis, fine. You told me compressive optic neuritis. Okay, can you give at least one or two? Okay.
Neuromyelitis optica. Neuromyelitis optica.
Okay, other than that, okay, let's move on. Okay, what do you want to do for this patient?
I would like to do a perimetry. I would like to do an OCT.
Okay.
I would like to do neuroimaging for brain and orbit.
Okay, before neuroimaging, what do you want to do? You told, right, the patient is having optic neuritis. So what do you want to do?
Check
Don't you want to do any lab investigation?
Check for signs and symptoms along with history of possible multiple sclerosis.
What investigation you want to take? Laboratory investigation. Just go step by step.
Okay, laboratory investigations for demyelinating disorders such as multiple sclerosis.
No. You name me. You tell me what investigation, laboratory investigation you want to do. Don't you want to take full blood count?
Yes.
Tell me all this. Yeah, what else? I mean, what you do if you see this patient in your clinic, just tell me that. What laboratory investigation you want to take? Okay, let's move on. So we're back to the imaging. Okay, what imaging you want to take?
Magnetic resonance imaging of the brain and orbit.
Okay, what is this picture?
There are three images. The left.
No, what is this? What is this? What imaging is this?
Magnetic resonance imaging.
Okay, it's MRI. Okay, so what type of MRI is this? I mean, if you see this patient, what investigation you can do in your center? What investigation you would do? I just want to ask.
There is post-contrast enhancement of the right optic nerve actually.
So, so you would go for MRI with contrast or CT scan with contrast?
MRI with contrast.
Okay. I think this is a fatal mistake. You can't pass this, you know. And you know why? Why?
No, sir.
Okay, I will tell you later. Okay, you describe this now.
Okay. Left image is T1 weighted MRI post contrast. T1 weighted MRI with contrast showing
Okay, what
post.
you see here? What you see now specifically?
Sir, which image, sir?
You can look in the center image only. What
Central
you
image.
see? What you see here compared to this?
Thicken is the thickening of the optic
Okay,
nerve.
okay. Thickening of optic nerve and sheath. Okay. Okay.
Yes, sir.
So what you want to do now after this?
I'd like to take opinion from a neurologist regarding the possible causes for this.
Why
thickening.
neurologists? What neurologists can do? Okay, it's okay. I will stop here. Okay, I think, okay, first of all, you did a fatal mistake. Can any of the candidates tell what is a fatal mistake?
Since she's a pregnant woman, contrast should not be used in MRI.
Exactly. This is beyond help, even examiner stuff. Okay, you don't do any invasive in pregnancy. Pregnancy must be very gentle. Even any medication you mention, you need to know. I consult the patient for the side effect and everything. Even eye drops. Can anyone tell me what is the eye drops and pregnancy? There is a class. Can anyone know about anti-glaucoma and what is the class of that for pregnancy? Okay, it's okay. Find out. Okay. Okay. So for this patient, basically you need to know a few differential diagnoses for optic neuropathy, and then how you need to be confident how you approach, and always go step by step and just think how you handle this patient in the clinic. Basic investigation only. Okay, and then how you approach this patient. Okay, if this is not a neurologist, you can refer to any neurosurgeon or oculoplastic surgeon. Okay, because this is something you find. Okay, so what candidate didn't answer the questions, but it's okay. Just that this could be optic nerve sheath meningioma. The diagnosis is not important. Most important is how you want to manage the patient. So basically, if I'm the doctor, I would say that I will just observe the patient, let the patient deliver. After deliver, I want to maybe refer to get the CSF fluid, or maybe in the future want to repeat back the MRI with contrast maybe later. Okay. Okay. Can we move? Okay. Who's going to try the third case?
So can I try?
And you are?
Dr. Febens.
Okay, Dr. Sabin. Okay. Okay, we start here. Okay, you look at this video. Okay, and then you describe now. Please describe.
Yes, sir. I can see bilateral conjugate nystagmus, which is I think pendular, and it is downbeating nystagmus. And
Look carefully again. Look carefully again. Okay, you look now carefully again. What type of nystagmus is this?
downbeating, I think it's
Look now. Look now. Look now. Let me give you help you. Okay, at this point. Okay. 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 You look now. What is this? Yeah. Okay. Look now. What is this? What type of nystagmus is this?
looks like an upbeating.
Okay. What if upbeat? How's the nystagmus would be? What is the first phase? What is the second phase?
Fast phase towards the upward direction.
Again, what?
Fast phase towards the upward direction.
No. Okay. Let's we say that this is upbeat nystagmus. Can you give some differential diagnosis?
The causes of upbeating nystagmus, sir?
Yes. Some differential diagnosis.
Most probably any pontocerebellar lesion or due to any drugs like any anticonvulsants like phenytoin,
Okay. Other than that,
alcoholism, or any
Okay, other
warnings,
than that?
encephalopathy.
okay. Other than that, what
Uh,
other possibilities?
cerebellar lesions
Okay, okay.
affecting the
Good.
vermis.
Okay, that's good, fine. Okay, let's we say that this is 28 years old female, complaint of blurring of vision and feeling oscillopsia past 2
Yes.
months, which is worsening.
Yes.
How you would approach this patient?
So since there is oscillopsia and it is acquired, we
No,
need,
how you would approach this patient? You start from the history, okay? How you
Yes,
tell
sir.
me?
So history, I would ask for whether the oscillopsia is there full time or
It's just developed past 2
And-
months.
yes. So I will ask for other symptoms of cerebellar dysfunction.
Okay,
Sir.
no other neurological symptoms.
No other neurological symptoms.
Think back
Then,
of your differential diagnosis. What you
Yes, sir.
tell in
History of any
differential-
intake of any drugs.
No any intake of drugs. Okay, others? Just now you told what? What is that? Other history you want to-
Cerebellar, any cerebellar.
No. Your differential diagnosis. What you told history that you should ask. Intake of what?
Also, intake of any anticonvulsants.
Other than that?
Alcohol.
Yes. Okay. No any alcohol intake. Okay. Now you examine the patient. Okay. What you want to do?
I would like to check the visual acuity of the patient.
Visual
How
acuity
much
is
it is
6/36 both eyes.
Okay, sir.
Come quickly. What else?
Then, apart from visual acuity, all other optic nerve functions will be checked.
All normal. All optic nerve function normal. Then
Then to check for any neurological, I mean, everything is normal. Neurological deficits. we will
okay,
check.
neurological, she only have upper limb and moderate upper limbs moderate ataxia and breast reflex and no weakness. Okay, so
Yes, sir.
in slit lamp examination, anterior and posterior is the examination all normal.
Normal. Yes,
Okay,
sir.
so what you want to do?
I would like to check for the cerebellar function, sir.
No, all normal. I mean, I already tell you, right? The only upper limb got moderate ataxia. What investigation you want to do?
You mean lab investigations or
Okay, can. Yeah, complete. What investigation you want to do?
mainly neuroimaging, sir, to rule out
Okay.
any problem
What
in the
neuroimaging you want to do?
MRI of the brain and spinal cord.
Okay. Okay, just wait a minute. Okay. Okay, what is this? Can you specific on the MRI? What type of MRI you want to? Okay, let's forget
This
about
looks
that.
like a T2 image with a flare, I think. So.
Okay. Okay, so what you see here?
You can see some periventricular plugs.
Okay, you see here periventricular plugs. Okay. So
Yes.
what? Okay, from now, what else you want to do?
Rule out other, I mean, to check for
If the patient
periventricular plugs means you have to rule out multiple
okay.
sclerosis.
Okay, fine. So what you want to do? If do you want to suspect multiple sclerosis?
So I would have to refer the, I mean, collaborate with a neurologist to
Okay,
rule out
very
other,
good. And what neurologists can do?
I mean, neurologists rule out other signs like
investigation neurologists will do?
CSF analysis for
Yes, CSF analysis will show what?
pleocytosis.
Other than that,
Oligoclonal band.
Oligoclonal bands. Yes.
I don't like people disturb me. Okay, who's the one that will disturb you? Who's there? No, let him answer. Okay, in exam nobody will help him. Okay, it's rude also. Okay, Okay,
Yes.
so what is the relation between multiple sclerosis and optic neuritis?
Like multiple sclerosis, you can get retrobulbar neuritis in multiple sclerosis.
No, do you know
So-
any studies that shows
Yes, sir.
relationship
ON
between multiple sclerosis and optic neuritis?
Yes, sir. Optic
What is
neuritis
that?
treatment
What is the
trial.
relation between multiple sclerosis and optic neuritis?
Optic neuritis treatment trial, where you can, as per the study, you can, if you're confirmed that it is an optic neuritis, you can, or a retrobulbar neuritis, you can start giving IV methyl
No. I don't ask you. You please find the question. My question is,
Okay.
what is the relation between multiple sclerosis and optic neuritis based on optic nerve treatment trial?
Relation.
Okay, fine. Fine is okay. Okay, you did quite okay, not that bad, but try to come with a systematic approach for the case step by step. Okay, and
Okay,
then
sir. Okay, sir.
nystagmus, yes, and basically don't jump once you see that nystagmus. Don't conclude that that is the type that you assume. Just open it and say it may be. So if you use that word, the examiner will help you. If you straight say it's pendula, conjugate, and everything, is very confident that you told, and it could be wrong, and you'll get into trouble. Okay.
Okay, okay, sir.
Okay.
Thank you.
Okay. Okay. Let's
Thank
we move on to the next case. Okay. Who's going to try case number 4? Hello. Anyone? Can you all hear me?
Sir, may I? Sir, Dr.
And you
Soumya.
are? Okay.
Soumya, sir.
Soumya, okay. Are you ready?
Yes, sir.
Okay. Please describe this.
This is a printout of the Hess chart of right and left eye. First of all, we'll look which chart is smaller. So the left eye
No.
chart.
You just tell me what you find. What's the pathology that you find here?
Okay, sir. The centration is towards the lateral side. So left eye is exotropic with limited lateral superior and inferior rectus actions.
Okay, you just tell me based on this S chart, which eye is the problematic eye?
So it appears to be the left eye.
Okay, so left eye. You just tell me look at the left eye, which muscle have problem?
Sir, probably a lateral rectus and even superior and inferior rectus also.
No. So what?
Okay.
What is
Lateral
this?
rectus is it, sir? No. Okay.
So which muscle you think?
Sir, medial rectus, because this eye is in exodeviation.
So this is the under action of the medial rectus. Okay, let's like if this is 68 years old female, develop double vision on looking up, worsen over 3 months. How you approach her?
Okay. Develop. Mm. Sir, is there any other ophthalmoplegia or ptosis as well?
No. You ask, you answer me how you would approach
sir.
to this patient.
Okay, sir.
Step by
First,
step.
yes, sir. First, I'll try to record the vision. And,
No, before the vision, what you want to do?
History I would like to take from how long she's having this.
3 months.
3 months.
Because-
Okay, you said. Yes, sir.
What else in the history you must take?
Sir, this diplopia, is it same at throughout the day, or does it vary?
Okay, same.
It's same. Okay.
What else important history you must take? 68 years old female.
Sir, history of any trauma or
No
any
history of trauma.
okay, systemic comorbidities like diabetes, hypertension,
Okay.
hyperlipidemia.
Okay, she is a hypertension, but well controlled, no diabetic. Okay, let's
Okay,
move on
sir.
to examination. How you would examine her?
Sir, firstly, the vision.
Vision is 6/9 both eye.
Okay, sir. The color vision.
Color vision normal.
Okay. Pupillary examination.
normal.
If normal. Okay, sir. Then cover uncover tests.
Okay. Cover and cover test. We noted that there is a right eye hyperphoria on primary case, which increase on up case.
Okay. Hyperphoria.
Okay. Then
Then ocular motility in all the gazes.
okay. Ocular motility, as you said, in this one, the medial is impaired. Otherwise, all looks fine.
Okay, sir.
Then how you do that after that?
Field, sir, by confrontation.
No, confrontation normal. Other than
Normal.
that,
Okay.
then now what
Sir,
you will do?
then fundus examination.
Okay, no, you tell slit lamp examination. So
Okay, yes,
anterior
sir.
segment and posterior segment normal.
Normal.
Okay,
Sure.
so what is your impression based on this?
Um, so there is a right-sided hyperphoria.
No, forget
Sorry,
about
left.
the right eye.
Achha.
Okay, the problem is left eye. So you step by
I'm
step, how
sorry,
you
yeah,
want
left.
to okay, first you find in your S chart, what is in the S chart, the problem? Which muscle?
Sir, left eye medial rectus is
Okay,
either
then,
paralyzed.
okay,
Yes, sir.
wait. You'll find in the S chart the medial rectus. Then in your confrontation test, what you find? Just now, sorry, in the cover test, what you find just now? I told you.
Sir, you said hyperphoria, which increases
okay,
in
so which
upgaze.
muscle is that?
Superior oblique. And
No, you find
sorry,
that the
inferior
right
oblique and superior
wait,
rectus.
Right eye, you show you find that it is hyperphoria. Okay, means that the left eye should be
Hypo.
hypo. So which muscle is that on the left eye?
Left eye is not going up. So either superior rectus or inferior oblique of the left eye are involved.
No. Okay, superior. Okay, we focus on the superior rectus. So the
Yes,
patient having a medial rectus and superior rectus. Okay,
Yes, sir.
problem.
Yes, sir.
So what is your impression now for the left eye?
Sir, because these two muscles are supplied by the third nerve, so we can take it as a differential diagnosis, third nerve paralysis or palsy.
Okay, so this is a third nerve involving superior division and medial division. Okay.
Yes, sir.
Okay, and then there is no any optic neuropathy.
Okay, sir.
Okay, so where is the
because-
lesion you think?
Sir, because she doesn't have involvement of the pupil,
No.
so we will have to do neuroimaging to rule out.
No. Wait. Answer. Listen the question first. Where is the lesion? There is a lesion, but where could the lesion be?
Sir, in the nucleus itself.
Why you think so in the nucleus? Where does the superior division and inferior divisions appear for the third nerve?
Sir, cavernous sinus.
Okay. Other than that,
Mm,
very specific. It's only involved superior and
Specific.
medial division. So where is it?
I'm not sure, sir.
Okay.
Fasciculus
Okay. Let's
also
say
there.
that it is could be also in superior oblique fissure. Okay.
Yes, sir.
Okay. So what's some differential diagnosis you can give?
Superior oblique fissure involvement. So it can be a Tolosa-Hunt syndrome.
No. Come on. Step by step. Tolosa,
Okay.
how frequent is Tolosa-Hunt syndrome?
Yes.
What is the presentation? Can you tell me the presentation of Tolosa-Hunt syndrome?
So there will be multiple cranial nerve palsies.
No,
This
how
is
is the
only
patient presented with?
Sir, with excessive pain and
So this is your dig your own grave. So don't
yes,
tell
sir.
like this. What is the
Yes, sir.
differential diagnosis?
Either there is compression in the cavernous
okay.
sinus or
Okay,
superior.
some tumor there. Okay, other than
Yes,
tumor,
sir.
what else?
Inflammation in the form of demyelination.
What infection you think could be?
Sir, I said actually inflammation, demyelination. I said.
Okay. What infection it could be?
Infection. Okay, infection. Sir,
Common
tuberculosis.
infection. Yes.
Tuberculosis,
Okay.
syphilis.
Okay.
Yes.
Okay. Okay, so fine. I want to ask you a question. Can you tell me some clinical signs of aberrant third nerve palsy? What
Yes, sir.
types of aberrant third nerve palsy you know?
Yes, sir. Aberrant third nerve regeneration. In
Yeah.
this, when the
No,
the
not this
patient.
question. I just want to ask you a question. Can you give me the findings of aberrant third nerve palsy?
Yes, sir. When the patient will try to adduct, there will be elevation of the upper eyelid, which is known as the pseudo-von Graffe sign.
Okay.
Also, when the patient will try to look down, there can be elevation of the upper lid. Similarly, there can be pupil gaze dyskinesia also. In adduction, the pupil will constrict, and
What is
also
called?
so that is called pseudo-Argyll-Robertson pupil.
Okay, what else? One more.
And so when the pupil looks down, the patient looks in depression, again the pupil can constrict.
Other than that, what in adduction?
In adduction, also there will be elevation of the upper lid, sir.
It's called what?
That is called.
Okay, it's
It's
called
just
inverse
slipping off my
2A.
mind, sir.
Okay.
Yes, sir, inverse. Yes, sir.
Okay, thank you. Okay, you did quite well, but just careful. Every words that you come from your mouth can bring you down or can impress the examiner. It's either two-way, okay? So
Yes,
just
sir.
careful, step by step. Okay, always approach neuro-ophthalmology step by step. Take from basic to the invasive. Any lab also from the basic to more complex laboratory investigation, okay? So let's
Yes, sir.
move to a final case. Who's going to try this case? Hello. Who haven't tried can try. Who's going for exam can try. Hello.
Hello,
Yeah. Who's there?
this is Dr. Anjana.
Okay. You want to try?
Yes, yes,
Okay. Are you ready?
yes, sir.
Okay. Please describe this.
This is a partial facial photograph of a patient showing multiple erythematous lesions.
Okay. Good. It's a multiple erythematous patches on the left forehead. Okay. Okay. Let me tell that this is a 5-year-old girl. Usually look object with a lateral gaze. Also often runs into things with right side. Okay.
Sir, I didn't get you, sir.
This is a 5-year-old girl, usually look object with a lateral gaze.
Okay, okay, sir.
Okay, also often run into things with a right side.
Okay.
Okay, so how you approach her?
So I'll do a complete ophthalmic evaluation, take a visual acuity.
No. How you would approach her? First, what you want to do?
I'll ask for a history.
Okay, what history you want to ask?
I mean, if the patient's left turn is from birth or it has been acquired recently.
Okay, it's just been acquired maybe about 1 or 2 years like this. Yeah.
So, if the child has difficulty in doing her work, like school work, which may point to defective vision.
No, not that difficult. Okay, what important history you must take?
So if the child has any seizure attack.
Yes, the patient is epileptic but on treatment. Okay, so let's we move on. What examination you want to do?
And should I start with a systemic examination or I can start with an
you
ocular?
can, up to you. You want to do ocular also is okay.
So ocular examination, I record the visual acuity.
6 foot eyes.
anterior segment examination.
Before anterior segment, what you want to do?
We should get color vision or confrontation
All
fields.
normal, all normal. What else?
And ocular deviation, since there is ocular deviation, and check for
Okay,
extraocular.
extraocular movement full. Okay, now you proceed with slit lamp. Okay.
Patient has left turn the cover uncover test also. I need to.
Okay, you proceed with slit lamp. Okay, anterior segment is normal. Okay.
Detailed
Hello?
dilatation, sir.
Wait. I tell you. Wait, I give you information. The anterior segment is normal on the slit lamp.
Okay, sir.
Okay. Posterior segment, you find this. Can you describe this? Hello.
Yes, sir. This is the color fundus photograph of both the eyes. Showing the this was there are well-defined margins in the disc.
What you find in the disc there?
The margins are well defined, and I don't know.
No, how can you don't know what is in the optic disc there? How you describe optic disc? You find about the margin. After that, what you must tell?
The cup disc ratio of about.
Okay, cup. Okay, so what is a cup here?
Right eye, there is increased cupping, sir.
So what cupping? Okay, increased cupping. I agree. So what cupping you think? Come on, this is basic. What is the cupping here?
It's cupping cup disc ratio of about 0.6 or and.
Maybe more than that. Okay, let's just tell that this is about maybe about 0.7 or 0.8. Okay.
And the left eye, the cupping, I mean, there is a
okay, both eyes is okay. Let's say that both eyes large cupping. Okay.
Yes.
Okay. Then
the neuroretinal rims.
No, that's all is normal. This is just artifact. Okay, all this normal. Okay. So what else you want to do now in your clinic that can do?
I examine the for other systemic features. I'll examine.
No. We go for investigation that you want to do
for this patient, sir.
Yeah.
Ocular investigations.
Okay, let's say that you do Humphrey visual field. Okay, so can you describe this visual field?
So based on this visual field, the fixation losses and the false positive errors are high. So the reliability is more. And,
obviously, right? She's 5 years old girl, so it's okay. It's fine. I'm not. This is not glaucoma session. Okay. So basically, you see that what is here? Look at this.
So it is a field defect respecting the vertical meridian. So it is a neurological field.
No. Okay. So what is the impression of this finding?
It is a applied homonymous hemianopia.
What homonymous hemianopia?
Incongruous.
No. It's okay. What homonymous, right or left?
Right.
So it's a right homonymous hemianopia. Okay. So okay, based on all these things, what the child having? You think? Look at the picture and then what the child is having likely.
Tuberous sclerosis.
Tuberous
sclerosis.
Okay. How frequent you see tuberous sclerosis? Are you from India?
Yes, sir.
How frequent you see tuberous sclerosis?
Very rare.
So why are you mentioning all this? So what is this?
Some malignancies.
What? No, you are doing
intracranial.
quite well. If you mention like this at the end point, it will be not good result for you. So what do you think it could be?
Bitemporal neurological fields, I do an imaging.
No. What diagnosis for this patient, roughly? Okay, we stop here. Okay, any candidate can tell what is the diagnosis for this patient.
Yes, can I tell?
Yes, who are you?
I'm Dr. Asad
Okay,
from
what is the
Riyadh.
diagnosis?
Like we see the pictures on angiomas on forehead, then
No.
cup disc ratio,
So what is
high
this?
and less and left. Yeah, this is right homonymous hemianopia, maybe due to
Yes, I just
Sturge-Weber
want to
syndrome
add the
and
word Sturge-Weber. Okay.
leptomeningeal.
Okay, so this is Sturge-Weber syndrome.
Yeah,
So who's the
yeah.
candidate just now answer? Can you please continue? Okay, do you know what Sturge-Weber syndrome?
Yeah, it is a.
Okay, what is that?
It is a leptomeningeal facial angiomatosis. This
Okay,
is a
so
one
what is
type
the
of
systemic features of this syndrome?
usually facial Sturge-Weber syndrome includes the facial hemangioma, and along with the leptomeningeus is involved, leptomeningeal hemangioma.
No,
And
what in the
also
skin you find? What is the name
skin,
of
I
the,
will find the skin. I will find the hemangioma.
what is the common name for that?
Sturge-Weber syndrome. That is the strawberry nevus here.
Can anyone tell in the skin what is the sign?
The port wine stain.
Yeah, it's a
Port
port
wine
wine. Okay, port wine. Okay, that's the means. Okay, candidate, continue. What is the ocular features of this syndrome?
Ocular feature, we can get the episcleral hemangioma, choroidal hemangioma, also the increased IOP due to the increased IOP we
Just
can
tell
get.
glaucoma. Okay, it's just a
Glaucoma,
glaucoma. Okay.
yes.
Okay, what is the inheritance of this disease?
It is autosomal dominant.
If you don't know, you just tell don't know. Don't say wrong word. Okay, this is not good. Okay, so just move on. Okay, what you want to do for this patient?
For this patient, for the hemangioma part, I want to observe the patient and also as the
No,
patient
not
also.
yet. We haven't completed yet, right? And now you what you think you know that you only up to the Humphrey visual field. Okay, so what other investigation you want to do?
I want to do the MRI for the patient to see any type of lesion in the.
Okay, fine. You want to do some imaging. What imaging is this?
This is MRV maybe. Magnetic
Okay, let's
resonance.
I say that this is MRA.
Okay.
Okay, what you find here?
These are the increased resonance of the. No, I'm not sure. I cannot.
Okay, I just want you to say that you are not sure. Okay, no, because you are not radiologist. Okay, so just that okay, you think that based on all your clinical signs and then your examination and also your Humphrey visual field, where is the lesion in the brain? Which side you think the lesion would be in the brain? Right or
I
left?
think it should be the left. It should be on the
good,
left.
fine. Okay, so how you manage this patient?
Depending on the neuroimaging, if there is lesion in the brain, I must send the patient to the neurosurgeon for handling the patient. In my case, for the ocular part, I can give the anti-glaucoma medication if he requires. And for the facial part, I can send nowadays there's lots of lasers are there which can
fine. Okay, you did quite well, but you cannot link the image and then investigation come to one conclusion. I'm sure you have seen Sturge-Weber syndrome, right?
Yes, sir.
Yeah, so that's how it is. Okay. Okay, that's all. Okay. For 5 cases. Okay. Yes, Dr. Kaushik. Yeah. Okay. I think Dr. Kaushik is somewhere. So these are only short cases only. Hope it is helpful for you all. Okay. Okay. Anyone? Okay, I think we can end here.
Excuse me, sir.
Okay. Yeah.
So
Okay.
there was a question in the past experiences that a lady comes who has a tightness of the wedding ring and excessive sweating. Sir, how do we approach it? These were the two symptoms which were given.
Oh, I'm also not that sure. I need to like if you I just tell that excessive sweating and tightening of the ring is I'm not sure also.
This
Okay,
is
sir.
an acromegaly case.
That candidate had given acromegaly. So should we speak in terms of thyroid as well, or only growth hormone excess?
Which case is this?
Sir, in the last session, like in the Bombay session, there was this case in which only these two factors were given. A woman comes with the tightening of ring and excessive sweating. So how do you approach?
This would
Should
be
our
if you see this is a clinical session, right?
yes, sir.
Yeah, so obviously you would find other sign also. This maybe the patient size, maybe the shoe, maybe there's some bone abnormalities. It look like acromegaly like this. If you've seen that is clinical.
And sir, if it is a written question, then should we go in terms of thyroid as well or not?
I mean, rarely they will ask a written question. Very
Okay.
yeah, it's more like a clinical. Each case would be different. Just if you are not sure, just go for the basic how you examine. Even you don't get the diagnosis is okay, but you need to
Yes,
go
sir.
step by step. Okay.
Okay. Thank you, sir.
Okay. Thank you. Okay, we can end here. Okay.
Thank you, sir.
Okay.
Thank you.
Thank you, Dr. Logan. Hello.